The next presenter is Ms. Vinie Kouamou from University of Zimbabwe in Zimbabwe. She's going to present the abstract number 8, Point of Care Samba-Ii versus Centralized Laboratory Viral Load Assays among HIV-1 infected children, adolescents, and young adults in rural Zimbabwe, a randomized controlled trial. Ms. Kouamou, please.
Good morning, everyone. My name is Vinie Kouamou from the University of Zimbabwe, and on behalf of the SIBA team today, I will present to you the topic, Point of Care Samba-Ii versus Centralized Laboratory Viral Load Assays among HIV-1 infected children, adolescents, and young adults in rural Zimbabwe, a randomized controlled trial. We all know that viral load monitoring is critical for viral load suppression and to achieve the third 95 global target by 2030. In addition to viral load monitoring, differentiated service delivery have been developed, implemented, and expanded mostly in Africa to meet the global target for HIV treatment. That's one of the reasons why the simplified amplification-based assay called Samba-Ii, which is a new point-of-care semi-quantitative HIV viral load test, was introduced at selected rural hospital in Zimbabwe in February 2018 to address the problem of viral load testing at rural sites. To achieve this, we conducted a randomized clinical trial of viral load monitoring among children, adolescents, and young adults who had been on ART for over a year. Participants were from Chidamoyo Hospital Clinic and from 8 rural outreach sites. Viral load monitoring was done by either point-of-care viral load by Samba at the clinic or standard-of-care viral load by Roche at the provincial referral lab. The primary objective was to compare viral load suppression at 12 months between the two arms, and the secondary objective was to determine the rate of drug switching and the rate of drug resistance among the participants. For viral load testing, whole blood collected in EDTA tube was obtained at enrollment 24 and 48 weeks of study. Plasma was harvested and stored at -20 within 6 hours of collection. The sample for standard of care testing were dispatched weekly to the provincial referral lab, while the one for point-of-care viral load testing were stored and assayed within 4 days at the clinic. For standard-of-care viral load testing at the provincial referral lab, the Roche assay Cobas Amplipep was used, and the result was returned within 8 weeks. For point-of-care viral load testing at the clinic, the Samba assay was run for 90 minutes, and the results were available to the provider within 72 hours. Differences between the study arms was analyzed using chi-square, Fisher-Exact test, independent t-test. For drug-resistant evaluation, baseline RNA was extracted from plasma and genotyped by Sanger sequencing, and the drug-resistant mutation were determined using the Stanford HIV database. Baseline characteristic at randomization. Altogether, 390 participants were enrolled. The median age of the participant was 14 years. Over half of the participants were female. The majority, 61 participants, were on a NNRTI-based regimen, and only 7% of the participants were immunocompromised at enrollment with a CD4 less than 200. The overall viral load suppression at baseline was 80%, and there were no significant difference between the arms. Characteristics associated with viral load suppression at baseline. We noted that participants who received care at the rural outreach site were more likely to be suppressed than participants from the clinic. Similarly, participants on an NNRTI-based regimen were also more likely to suppress compared to those on a PI. Viral load suppression and characteristics associated with viral load suppression at 12 months. A total of 347 out of the 390 participants that were enrolled at baseline reached follow-up at 12 months. The overall viral load suppression was 80%. When we adjusted for the 43 lost to follow-up, there were no difference in viral load suppression except for adolescents versus children. Only age greater than 10 years and viral load greater than 1,000 copies at baseline predicted virologic failure at 12 months. Since we were assessing the role of a new point-of-care viral load testing at rural, we then analyzed the rate of confirmatory viral load testing, test result turnaround time, and drug switching. A 6-month follow-up among the 69 participants that had a viral load greater than 1,000 copies per ml, 72% had a confirmed viral load test performed. The frequency of confirmatory viral load testing was significantly greater for point-of-care viral load testing versus standard of care. The turnaround time for confirmatory results was significantly shorter by the new point-of-care viral load testing at the clinic compared to standard of care at the provincial referral lab. A 12-month follow-up, a statistically significant turnaround time was observed when confirmatory viral load testing was done by point-of-care viral load testing at the clinic versus standard of care at the provincial referral lab. However, there were no difference in rate of drug switching between the two arms. Genotyping resistant testing was carried out among 24 participants failing on a second-line PI-based regimen. Drug-resistant mutations were identified in 19 of the 24 participants. Resistance to PI was rare and it was identified in only 4 participants. Dual-class resistance to NRTI and NNRTI was detected in 10 participants. Interestingly, after a median duration of 7 years on a boosted PI, resistance to NNRTI was found in the majority, 17 of the participants. In conclusion, point-of-care viral load provided earlier and efficient confirmation of viral load suppression, but with similar results for drug switching. Viral load suppression was achieved in 80% at 12-month follow-up among children, adolescents, and young adults in rural Zimbabwe. Viral load suppression was significantly greater over 12 months in participants in care at the rural outreach site and was less likely among PI recipients regardless of being at the rural outreach site or at the clinic. And because of PI failure, access to integrate strain transfer inhibitor-based steroid regimens are needed to achieve 95% viral load suppression among children, adolescents, and young adults in rural Zimbabwe. I would like to end my slide by acknowledging the study participants and staff, the Chidamoyo Hospital Clinic, and the sponsor. Thank you very much.